So I'm a lawyer, and my understanding is you are student midwives. Is this correct? So raise your hand if you are here at the university studying midwifery. So, okay, so most people are midwives. Anybody else want to share where they come from or what they study?
I'm a doula.
Okay.
I just came to.
Cool. Yes?
I studied
Doula also. Amazing. Advocates. And you?
Okay, I'm a teaching consultant.
So, okay, so everybody works in maternal health, and everybody here is women, except for our wonderful translator. Thank you. And so this pertains to why we're here, because advocating for midwives is advocating for women. I came into this work because I'm an American, and in America there's not a lot of midwives in our maternal health system. United States is maybe even unique in the Western world in the way midwives were completely wiped out of American healthcare early in the 20th century, in the 1920s and the 1930s. Shall I pause? I talk fast. Okay, you tell me if I should pause for the catch-up. And so, and at that time, then childbirth was given entirely to doctors and nurses, and babies were delivered. And this is when the United States developed the stork, the forceps and the episiotomy, and there really was, childbirth was highly managed through medical obstetrics for 50 years, until the 1970s, when hippies started to rediscover that there even was such a thing called midwives, and to reinvent them. And so slowly, slowly, over the last 50 years, there have been more midwives in the United States, but still, it's very different all over the United States. It's a patchwork. In some states, we have different kinds of midwives now. We have nurse midwives or direct entry midwives. And in some states, nurse midwives are allowed to work, but only under the doctor. In other states, they can be independent. In some states, the direct entry midwives can do home birth. In other states, they're underground and they're criminals. And so, but myself, I moved to the Netherlands when I was pregnant with my first child. And I gave birth in the Dutch system. And in the Dutch system, midwives are very strong. And in fact, they're the first line of care for healthy women. And so moving there as an American, I was 7 months pregnant. I call the insurance company and I say, oh, hi, I just moved here. I'm 7 months pregnant. And they said, oh, are you giving birth at home or in the hospital? Because Holland, as you may know, is the one Western country that never moved healthy birth into the hospital. Their whole tradition developed with the understanding that if pregnancy is healthy, you give birth at home with a midwife. And until the turn of the century, if you wanted to, I mean, by which I mean 2000 or so, if you wanted to give birth at the hospital and you did not have a medical problem, you had to pay out of pocket. But by the time I'm there, you really had a choice. I said, well, I'm having a healthy pregnancy, maybe I give birth at home. And within a week, the insurance company sent me a box of home birth supplies. And I knew that I could choose this because it was integrated into the system, because it would be treated like a normal choice. In the United States, if I gave birth at home, I had heard stories of women who try to give birth at home. First of all, to even find a midwife was like a drug deal. And then if they give birth at home, if they have to go to the hospital, they would be mistreated, or they would be neglected. They would be treated like that decision was a bad decision. They were bad girls for making it. And it was easy to see how that kind of treatment would make the situation more dangerous and could result in death, because neglect leads to delay. And as you know, in childbirth, delay is not safe in emergencies. So I was in Holland, and so I gave birth at home with my midwife twice, in 2007 and 2010. And in the meantime, I started to teach law. I think my second year there, I taught law. I started teaching law in The Hague in an international law program. And I got to study, while I taught, about maternal health systems and why they are the way they are. And I discovered that, in a way, the way women are treated in childbirth around the country, around the world, is a reflection of how women are treated in each country. And you can directly measure the way that women are treated in childbirth and the way that women are treated in general by the strength of midwives in each society. So the country with the strongest midwives and the best maternal health system is probably New Zealand. And New Zealand is the country where women first had the right to vote. And the Netherlands is actually the first country in Europe where women could own their own property. And so around the world, and even around Europe, you can see with each country, the way women are treated in childbirth reflects their status in that society, so that Northern Europe has pretty strong midwives, pretty good maternal health system. When you get closer to the Mediterranean, culture gets more macho, C-section rate goes up, obstetrics is more controlling of the whole picture. So I find this very interesting, because childbirth is a universal physiological process, and human rights are fundamental. And yet you can see these issues play out differently all over the world. And so I suppose I can tell you that I got into this work as a lawyer when my midwife first got a complaint filed against her by the doctor in the hospital for supporting women to have their twins at home. And I went and I talked to the mother of the twins, and she would have preferred a hospital birth. But when she came to the hospital, she was planning, it was her fourth birth. She had a master's in mathematics, she'd read all the studies, and she was ready to make informed decisions about the births of her twins. And she was planning a vaginal birth. She was not planning a C-section unless it was actually necessary for her. And so she came in at 38 weeks. Different doctor was on call than usual doctor. And the doctor said, let's plan your C-section. You know what I mean by C-section, cesarean surgery. And she said, well, could we talk about the risks and benefits of a C-section for me? She's asking for individualized analysis. She has every right to this information. What she's asking for is informed consent. And the doctor responded, who's the captain of this ship? And she said, I'm the captain of the ship. And he said, I'm responsible for those babies. Actually, she said, I'm responsible for those babies. And the woman said, I'm responsible for the babies. And the doctor went straight to coercion. And, oh, you don't care if your babies die, but not telling her why the babies would die. You know, there was no medical information being communicated, only pressure and coercion and threats. And so she left, and she sought the one midwife who would drive 2 hours to support her in childbirth. And so then I realized how these things fit together: the mistreatment of the woman in the hospital, and then the legal treatment of the midwife who shows up for her, the complaint against the midwife who shows up for her and gives her any other option. And as an American, thinking about things through a capitalistic lens, you can think about how people are going to treat you differently if they know you have somewhere else to turn than if they know that you have nowhere else to turn. And so it is for obstetrics. And so now my work consists of 2 parts. Now, I moved back to the United States in 2012, and I started doing legal work in this area. And so half my work as a lawyer is defending midwives and advocating for access to them. In the United States, that takes many forms, including even advocating for them to be paid a sustainable wage so that they can do this work and be paid. And then the other half of my work is suing hospitals and obstetricians for the abuse of women, because the woman is the captain of the ship with regard to her own body. And any confusion regarding that fact leads to abuse and leads to trauma. And in my work in this area, I started listening to stories over the years. First, just my girlfriend's stories, and then to more stories, and discovering how often women would break down crying when they told the story of their baby born. If you really listen to the story, if you let them get past, oh yeah, it was bad, but at least the baby's okay. If you let them really tell the story, there'll usually be a place where they start to cry. And when they're crying, I would think, they don't get to do that to you. There's something called informed consent. They don't get to just do things to your body. They don't get to bully you if you want to make a different choice than they're trying to push you into for their convenience. So advocating for midwives, you know, here in the Czech Republic, there are midwives. There always have been. You were never wiped out. But the question that you get to ask yourself is, how secure are you as a profession? What is your ability to really stand with women in their individual needs? To what extent do you feel pressured as midwives to do things the way they're done around here, to do things the way they're done at the hospital, the way they usually do things, rather than seeing the human being standing in front of you and what she actually needs or wants for the birth of her child? Because the thing about childbirth is it can actually go a lot of different ways. You could have 10 patients with the same clinical chart and have 10 different births in terms of what they want for pain relief. Do they want a midwife? Do they want a doula? Where do they want to give birth? Do they want induction of labor? Are they going to have a C-section? And if you really meet the person, the individual, then you're going to be prepared for that variability. Some of the questions we'll consider today are, you know, I'm aware that there was a recent decision from the Court of the Czech Republic, the High Court, that midwives can support women to give birth at home, but if they do so, it is not health care. And so that gets to the question, and when they say, because it's not health care, therefore we will not regulate it. So that's a really important question for you as midwives to think about is, what is the role of regulation in protecting your ability to work and to do so ethically? Does it make you more safe or less safe? Does the regulation that controls what you do as midwives allow you to uphold the rights of your patients, or does it pressure you to violate those rights? These are important questions for the regulation of midwifery. And to understand them, you have to understand the history of midwifery in Europe. And so we're going to talk about that. So to understand midwifery in Europe, yes, Lenka? Is it okay?
Just ask me about the translation.
Is it working?
Yeah.
Okay, amazing. Okay, amazing. So, there have always been midwives, women helping women to give birth. And this book here, Contraception and Abortion from the Ancient World to the Renaissance, this man, he was a Harvard botanist, actually, he studied the herbs for contraception and abortion in the late Middle Ages. And what he discovered was that in the late Middle Ages, women in Europe had such a highly developed knowledge of the herbs for contraception and the herbs for abortion that they were having 2 to 3 babies each because they could actually control their fertility at that time. And then in the 12 and 1300s, there were a couple of little ice ages of 3 years where crops failed repeatedly. And then after that, the Black Plague came through Europe. And by the time 2 Black Plagues had come through, the population of Europe had been cut by 50%. And after it had reduced 50%, the owners of everything, the feudal lords who owned all the land, and the ecclesiastical lords who owned the church, started to write each other letters complaining about the shortage of labor. And for the labor shortage, they blamed women's secrets. And by women's secrets, they meant that knowledge of contraception and abortion that allowed women to control how many babies were being born. And so, right at that time, or in response to that, the Catholic Church issued this book, the Malleus Maleficarum, or Witch Hammer, that defined this new crime, Catholic crime of witchcraft. And they actually defined this crime of witchcraft in a chapter headed Midwife equals Witch, because the midwives, of course, were the people who held the knowledge of the herbs for contraception and abortion throughout Europe. And so they defined witchcraft as basically anything that would enable people to have sex without making a baby. So that meant homosexuality, bestiality, contraception, or anything that allowed for sex without making new life, or abortion, anything that took the spark of life and enabled it to not result in a human being. These were all now witchcraft and punishable by torture and death. And so this is what they said: no one does more harm to the Catholic faith than midwives, which is fascinating when you consider midwives as the people, as the holders of female reproductive autonomy. And here we must refer, they wrote, to witch midwives who surpass all other witches in their crimes. And the number of them is so great that there is hardly a village to be found without at least one witch. And so for 300 years, the European witch hunts focused on midwives. And these are all quotes from histories of the witch hunts. Without doubt, the midwife of the village was the most endangered person. In most cases, the witch hunters turned first to the midwives. And in every witch hunt, the local midwife was the person mainly to blame. And you guys can all have this PowerPoint after this. I'll make sure you have it and you can translate it or read it at your leisure. And there would be trials of these midwives, again, for the crime of the crime here was women talking to women about women's sexual and reproductive capacity. This was now a crime punishable by torture and death. And they would release these propaganda pamphlets that would be read about these midwives and their murder. And so you can, now that we know something about epigenetic trauma, it might be worth considering the epigenetic trauma of 3 centuries of women suffering torture and death for trusting each other, for communicating with each other, and for understanding how their bodies worked. These were the kinds of images and etchings that would be circulated. They would come after the midwife. There are studies that establish this. Then the women around the midwife and the women around them, until there were villages with 2 women left standing at the end of the witch hunt. And so into that space stepped obstetric medicine. Because in all of the murder of all of the midwives for contraception and abortion, they did not ask them anything about how do women's bodies work with childbirth, and how do we make safe childbirth happen. And so obstetrics was developed with the idea that the patient is modest and their naked body cannot be seen. So in fact, obstetrics developed on the bodies of corpses. There's a wonderful book by an Irish sociologist named Jo Murphy Lawless called Reading Birth and Death, about the history of obstetrics. And she describes this history of, because no live woman would allow herself to be seen, or so was the assumption, they would actually learn how babies come out of vaginas on dead women who could not move, and babies that could not move. And so all of the assumptions of obstetrics and the extraction of the baby came from that place. And so I know this is a lot of words. I can summarize, and you can read it later. But there was an oath that midwives then had to swear out. So midwives were allowed to keep working after the witch hunts, or new midwives were allowed to be, but these were different midwives. These were now, the women who practiced midwifery after the witch hunts all had to swear out an oath across Europe. And this was the oath to the state. And that it was essentially from that time an oath to betray the women they were serving. So for example, the midwives had to promise that if the father of the baby was not known, they would use the woman's labor pain to get that information out of her so that the father would be known. They promised to report any bastard, that is, any child born outside of marriage, the midwife promised to report. She promised, of course, not to facilitate any kind of contraception or abortion. And she promised to report her fellow midwives for any transgression or violation of these duties to the state. This guy's story is worth knowing. If you don't know it already, you should. Ignaz Semmelweis was a Hungarian obstetrician. He was the chief of obstetrics in Hungary in the middle of the 1800s. And he noticed, he decided he wanted to find out why so many women were dying in childbirth in his hospital. And actually he noticed that in his hospital, the main hospital of Budapest, in the midwife ward, the women had a much lower mortality rate than in the doctor ward. And so he wanted to find out why. And so he started studying it. And what he noticed was the difference between the midwives and the doctors was that the doctors were going straight from working with dead bodies into the labor ward, and without washing their hands because germs were not understood at that time. And so they would put their infectious hands from dead bodies and corpses into women while they were birthing, and then the women would get puerperal fever and die. And so he implemented this policy at his hospital to make the doctors put their hands in lye, to kill the germs on their hands. And as soon as he did it, the maternal mortality rate dropped to the level of the midwives. So he started publishing papers to the other doctors to say the maternal mortality in the hospitals is us not washing our hands, and we can end it. And the other doctors were offended. They were offended by his theory because they said they were gentlemen, their hands are clean. How dare you suggest that we are causing these deaths? Women are dying because of women's broken bodies, not because of anything we would do. And the other doctors out, he could control the doctors in Hungary because he was the chief obstetrician, but he could not control the doctors in Germany or the surrounding countries, and none of them would listen to him. And they, in fact, were offended and would argue and debate with him. So the chief obstetrician from Germany made it a policy in his country that the doctors had to go straight from the autopsy to the labor ward. And what happened to Ignaz Semmelweis was he became more and more passionate on this issue. He published. He spoke about it at every meeting. Finally, one day, he stood up at the regular physician meeting of his fellow obstetricians, and he said, instead of giving his usual rant about washing the hands, he recited the midwife's oath. And he basically said, I quit. I'm going to become a midwife because you all suck. And they immediately, after the meeting, called an emergency meeting of his fellow obstetricians to have him declared insane without his knowledge. They then went to him and said, Ignaz, we need you to help us do a tour of the local insane asylum to make sure that it's safe for the patients. He went with them. When he got there, they strapped him down onto a board to have him committed as insane. He struggled against the straps. They cut into his arms. He got gangrene, and he was dead 2 weeks later, 2 weeks after he stood up to recite the midwife's oath. And sometime after that, the physicians had to admit that, in fact, the germs on their hands were killing women. Now, I got that story because I went to the United Nations Commission on the Status of Women, and there was a hall, Ignaz Semmelweis, Savior of the Mothers. But it's worth considering how the culture of obstetrics responded to his effort to ally himself with those women. Agnes Gareb, 150 years later, another Hungarian obstetrician who actually, when she was an obstetrician, she was the first doctor to allow fathers into the hospital room, and she was suspended for doing that. And now that hospital likes to brag, it was the first to allow fathers into the hospital room. But when she witnessed so much abuse of women as a doctor, she quit and she retrained as a midwife. And she started offering out-of-hospital birth to Hungarian women, with the result that she was arrested and put on house arrest in her apartment for 3 years. There was a court order ordering her never to talk to a pregnant woman, as if she's like the Pied Piper. There becomes this attitude towards some midwives, that they're like a Pied Piper. They're going to play their little toot on their horn, and the pregnant women will all follow them off to a dangerous place. So in fact, midwifery is a political act, and standing by women is a radical act. So that's the background for the sort of framing of childbirth as we know it today. But again, there were forks in the road. Here's modern childbirth in the Netherlands in the 1940s. They, as a society, conceived of childbirth as something that is a family affair. It's a normal affair. Their basic framework or approach to childbirth is the midwifery model of care, which is that pregnancy and childbirth are normal physiological events with the potential to become medical events. But as long as they are normal physiological events, they are family events, they are human events, and they're events that appropriately belong in the home. Meanwhile, this was childbirth in the United States at the same decade. At this point, there were no more midwives in the United States. They had all been wiped out, and obstetrics had moved into the hospital. For me, one of the most amazing things was to learn that all of these images of childbirth that I grew up seeing, of the baby held up by the legs and hit on the bottom and put in the box in the nursery, they were all based on a generation or two of women who gave birth under general anesthesia. That's why the babies, if you should know as midwives, babies don't need to be hit to breathe. A baby that comes out breathes naturally unless their mother's under general anesthesia. And then the baby can struggle to breathe. And so they use violence on babies because they did not conceive that babies could feel pain. And the mother was knocked out, so they took the baby down the hall to the nursery. But none of that, as you all know, is what is normal childbirth. It's a medically managed childbirth. This is modern medically managed childbirth. For a third of women in the United States, in many countries it's over 50%. In some places it approaches 100%. There are places in South America where now the obstetricians say, you can't ask us to do a vaginal birth. We don't have those skills anymore. And when that's the case, and that's certainly the case regarding physiological childbirth in the United States, doctors don't know how to do that. They're not trained. They don't have experience. Women who have a natural birth in the hospital always talk about everybody coming to their room and saying, oh my God, we never saw that before. And when you have that kind of a medical environment, midwifery becomes really essential, because the only people who actually retain that knowledge and expertise in how women's bodies actually work are midwives. And so if midwives aren't allowed to develop that knowledge and to practice it and to maintain it, the knowledge is lost. And when the knowledge is lost, that's the knowledge of literally how women's bodies work. This is vaginal modern childbirth in many cases. It looks a lot like surgery. And as in this picture, where is the human being birthing that baby? There's a baby. It's pretty clear that that's a focus of this equation. All of these people are focusing on the production of the baby. But what happens to that human being? Because I think what you know or are starting to know is that that human being walks into the hospital full of hope, full of excitement and joy, and usually doesn't understand that this is what's going to happen. And when that disconnect can cause mental health injuries, it can cause physical injuries. You could call all of this a physical injury. But it also causes mental health injuries in the form of trauma, PTSD, among other, depression. And so at the heart of it, when we're talking about midwives and when we're talking about the people who are giving birth, really comes down to this question of who's allowing who to do what. Because when my midwife in the Netherlands got that complaint against her for doing twins, I thought, you know what? I thought I had a choice in this country about where to give birth. But it turns out I was allowed, and she's not allowed. So even here in Holland, we have the same confusion as everywhere else, which is who's allowing who to do what when it comes to the body of a birthing woman or a pregnant patient. You own your body all the time, including when you're pregnant. And if you don't, then who is the captain of the ship? And if the goal is to protect the baby, who is looking out for the baby? Is it the on-call obstetrician or nurse or midwife that just came into the room and thinks they know what's best in the situation? Or is it the person who's actually grown that baby out of their own flesh and blood for the last 9 months and are going to be mothering it after they go home? So all of these questions are at stake in maternal health care everywhere. Women are going into care, giving birth with providers who are unclear about whether women are allowed to do whatever they want with their bodies. They can tell them if they're not allowed to give birth vaginally. Maybe they're not allowed to give birth vaginally if their baby is breech. Maybe they're not allowed to give birth vaginally. And again, not allowed to give birth vaginally. This is a physiological process. What does it mean for anybody to tell a woman, you're not allowed to go through the physiological process that is the inevitable end of this pregnancy? Instead, you must submit to a surgical delivery. That's what modern obstetrics positions itself as having the authority to say to women. Are you allowed to give birth at home? Are you allowed to give birth with midwives at a birth center? Are you allowed to give birth to a midwife with a midwife at all? Who decides? Who decides that? Are you allowed to give birth with nobody? In the United States, more and more women are giving birth alone because they can't find any other place where they feel safe. And everybody knows childbirth is deadly. So when so many women are giving birth alone, what does that say about feeling safer to give birth alone than with any of the licensed professionals available to them? It says something about those spaces no longer being safe for women, if they think they're going to be safer alone than they would with any of the people available to them. Are they allowed to decide when they have a baby at all, or with whom? And if they're not allowed, who is making the decisions? Who allows or disallows the woman to do what she's going to do with her body or what she wants to do? Who is the captain of the ship? So legally and bioethically, it is the patient, and that includes when the patient is pregnant. These are the basic principles of informed consent. And these are universal bioethics. So as I explain this stuff to you, ask yourself, where are you being taught these facts in your midwifery education? Because there is nothing more important than this slide that you are going to learn before you go be a midwife. This is it. And if anybody tells you that it's anything other than this, they are leading you into abusive care. So let's talk about what this involves. before anybody does anything to the body of a patient, they have to tell them what they want to do and why. You don't get to just come in and say, we're going to do this to you now. Before you do something, you have to tell them why, because the default is to do nothing. So if you want to do something to somebody, the question is why? And what is it you're suggesting to do? If you want to put a pin in the baby's head or a screw, explain that to them. What is it? What is it exactly you want to put into their vagina and put into the top of their baby's head? What exactly are you proposing to do and why? And if you have to answer why, then you actually might have to answer, is there an evidence basis for this thing? How strong is the evidence that putting that screw in the baby's head is going to lead to a safer outcome? Is there some sign in this person's labor that they need it? The screw is just one example of something that's often done, like, we're going to do this to you now. Women come out saying, I thought it was a sticker. You have to tell them the risks of the thing that you want to do, honestly. So this first part, inform, this is objective information. This is not manipulation, where manipulation is emphasizing the risks of the thing you don't want them to do and emphasizing the benefits of the thing you do want them to do. Information should be objective. What are the risks of inducing their labor? If you're going to give them a Pitocin and misoprostol to induce their labor, what are the risks of that? Do you know the risks? Because whoever is telling them about that needs to know those risks, the risks to the mother and the risks to the baby. And then what are the alternatives? What are the alternatives, including the option of doing nothing? So, for example, induction of labor for slightly elevated blood pressure. This is a big trend in the United States of inducing labor at 37 weeks when either the diastolic or the other one goes over 140 or over 90. They're now telling women you have to be induced tomorrow. So there's an alternative to that. It is to just increase monitoring. It's just gestational hypertension. It's mild gestational hypertension. It's not preeclampsia. And yet they're not saying either gestational hypertension, they're not saying preeclampsia. They often say preeclampsia, even though she does not have it. But so the question is, what's the alternative? There's an alternative to do nothing. There's an alternative to do increased monitoring. And then what are the risks and benefits of each of the options? That's accurate information. What are the risks and benefits of each of the actual options available to you? That's part one, inform. Part two can be advise. So you don't have to necessarily have an opinion about each of the choices available to your patients, but sometimes you will have a recommendation. And that's where you give it. After you give them the objective information, then you can give your subjective advice. What do you recommend they do and why? And as you do that, understand that your perception of what's best is based on where you're standing. And what the law of informed consent, when judges write about it, what they always recognize is the person making the decision about their health care makes it on the basis of a lot of facts, not just the medical situation, but their values, their personal situation at home, in childbirth, their postpartum care, their past trauma. They get to make their decisions on the basis of all those things. And so you might think you know what's best. It's just a recommendation. So when you give it, don't be too attached from the ego, because to advise them is to understand they might accept your advice, they might decline it. It's not personal. But you can tell them what you recommend and why. And then the next part is to support. Support that patient in making their own best decision. And what that looks like is answer their questions and make clear to them that you're going to support them whether they do what you recommend or they do the other thing, that you're still going to be there supporting them in having this baby. That's what informed consent should look like. Does this apply in childbirth? Yes, it does. This is this American College of OB-GYNs, obviously it has no authority over here, but they do have this great statement on women's rights to make their own decisions during childbirth. And they say informed consent is incompatible with pressure. They say they're talking to obstetricians, and they say, first of all, pregnancy is not an exception to the rule that every patient gets to make their own decisions, including decisions needed to save life. Because again, that's the law. You get to make your own medical decisions even when life is at stake. And in the case of pregnancy, that means even when the baby's life is at stake. So of course the baby's life is at stake. It's childbirth. And so the question is, does the fact that the baby's life is at stake mean that the woman doesn't get to make the decision? Mean that somebody else is going to make the decision? No, it doesn't. Which comes back to the question of who is in the best position to look out for that baby? Do you want it to be the woman, or do you want it to be somebody else? And if so, who do you want it to be? Who's going to be in the best position to make that decision for her? Especially given that we have 30 years of research that shows that the overuse of cesarean section and other interventions is driven by physicians' convenience, their time convenience, their financial incentives, and their preferences for delivery. Everybody has their own perspective at play in the recommendation, but the question is, who's in the best position to make the decision? ACOG recognizes it's the woman, and they say, and that is incompatible with pressure or manipulation. And so again, ask yourself, as you do your rounds as midwives, as you watch other midwives work, as you watch doctors work, is anybody doing this stuff? How much would change in labor and delivery if before anything was done to that birthing patient, someone looked her in her eyes, told the patient what they want to do and why, explained the risks honestly, told her about the alternatives honestly, answered all her questions, and supported her best decision? How much would change in what you see every day? That fact shows you the gap between law and bioethics and the culture of obstetrics and what actually happens in labor and delivery. That gap is illegal, and it's a violation of birthing women's human rights. These guys, ACOG, that is, they make clear in that statement the reason that midwives and doctors should not pressure patients in their decision making. They say, remember prognostic uncertainty, meaning we're uncertain about, we can think the baby's going to die. We don't know. Just the EFM, CTG, is notoriously unreliable. There have been many cases in the United States where doctors call the judge and ask for a court order to force a woman into a cesarean section, and the woman escapes the hospital and drives somewhere else and birth her baby vaginally, healthy, even though the doctor called the judge to say the baby's going to die if you don't give me the authority to cut her open right now. And it's often for reasons like prior cesarean sections. So again, that's not, with childbirth, we're not usually talking about black and white situation. We're talking about higher and lower probability of risk. And these are complicated analyses that different providers have different perspectives on because they are so complex. So have some humility regarding prognostic uncertainty, and they also say, and the limitations of medical knowledge. This quote, while the health of a few infants might be preserved by overriding women's decisions, the health of many more may be sacrificed. And why would that be? Because when people are traumatized by their providers, they don't come back to the hospital. That's one way. And also because when the women go home, traumatized themselves or depressed from the way they were treated when they were having the babies, it undermines the baby's health. The babies need their mothers to be well. So another thing for you to consider when you're watching informed consent happen in obstetrics, whose values are shaping the risk analysis when you're talking about patients or when you're talking to them? Whose values, when they say this is the safer choice or this is the best choice, whose values are shaping that analysis? Generally, medical risk in childbirth, when they say this is the safer option, this is the more dangerous, they're talking about short-term perinatal risk. So that, you know, for example, with breech, the Hannah Breech trial that led to so many doctors and hospitals around the world saying we will no longer support vaginal breech birth was based on there was one study that has since been disproven, but it doesn't even matter. Many women are told your baby is breech, so you must have a C-section. And the most that 25-year-old study showed was a slight increase in short-term perinatal risk, short-term risk to the baby. It did not look at long-term risk to the baby. It did not look at risks to future babies, and it did not look at any risk to the mother. And this is very often the case. So when you're having these conversations about what is safer, what is more dangerous that we offer in our hospital, that we support with a woman's choice, what's the actual, are you talking about the risks to the mother as well? Are those even factoring into the conversation? So now, I'm sorry for all these words up on the screen. I know it's terrible. But the words are worth talking about because they pertain to the status of midwifery in the Czech Republic. There was this case before the European Court. So the situation with midwifery in the Czech Republic outside of the hospital is that it is not secure. Midwives cannot really safely attend women wherever they want to give birth. And of course, if you really want to support physiological birth, that happens outside the hospital. It's actually much more challenging to accomplish inside the hospital, where there's so much, again, pressure from the institution to follow its practices. So Hungary, that place where Agnes Gereb was put on house arrest, this woman, Anna Ternovsky, brought a case to the European Court of Human Rights. Agnes Gereb was her midwife, and she had her first baby at home with Agnes Gereb. And then she brought this case to the European Court of Human Rights, and she said, I'm pregnant again with my second baby. I want to give birth at home with my midwife, Agnes Gereb, but the legal situation around home birth in Hungary, this was 2010, the legal situation is, it's not regulated. It is not treated as a normal part of the healthcare system like it is in Holland. And so there's so much uncertainty around it that it's kind of an underground choice. It feels like my midwife is not legally secure to be able to attend me, and none of this is okay. This is all a violation of my right to give birth to my baby where and with whom I choose. She brought this case to the European Court of Human Rights, and they agreed with her. And they held in this case, they said a woman has a human right under the right to privacy, which covers off a lot of our rights to reproductive choice. They said just as a woman has a right to choose whether to bring life into the world, a woman has the right to choose where and with whom she gives birth to that child. And that includes home or hospital, and also doctor or midwife. And they held that the state violates the human rights of the woman when the state fails to regulate out-of-hospital midwifery in a way that respects the rights of the woman and integrates out-of-hospital midwifery into the system. And it ordered Hungary to do so. And then there followed a couple years later a case here in the Czech Republic, Dubska versus the Czech Republic, in which somebody brought an action here to say, okay, so under Ternovsky versus Hungary, all European nations should now regulate out-of-hospital midwifery and integrate it into the system. And the Czech Republic refused. It said, we don't want to do that. We think home birth is dangerous. They brought in as their expert America's most misogynistic obstetrician, who publishes article after article about how women should not be allowed to make choices. And they got an opinion from the European Court of Human Rights saying, okay, Czech Republic, we won't tell you what to do with your women. You can leave home birth and out-of-hospital birth unregulated. And so it remains. From what I understand, the court now has followed this up here in the Czech Republic to say, we're not going to regulate out-of-hospital midwifery. We are going to allow it. They're not criminals, but it is not health care. And so it puts it right back in the situation that Anna Ternovsky brought the lawsuit over. Because even if they say, oh, don't worry, we probably won't prosecute your midwives, they left the choice for out-of-hospital birth underground. And so that's why I put this language up here, because the way that judicial opinions work, when a court makes a decision, a high court like this one, the judges of the court, because they'll usually have multiple judges, they issue an opinion explaining their decision. But sometimes one of the judges or two can write an extra opinion where they say, we agree with the whole majority, but we want to make an extra point. So this comes from a concurring opinion in Ternovsky. And this judge wrote, we want to clarify why protecting the freedom to give birth where you want requires regulation. They say, in 19th century, we thought about freedom as the state should not interfere. We often think about liberty and freedom as meaning that the state should not try to control our choices. But then they say that doesn't work in the modern state, specifically with healthcare, because healthcare in the modern world is so highly regulated, and it occurs in regulation, such that to leave something outside of regulation it says when regulation is the default, only what is regulated is considered safe and acceptable. So in healthcare, when everything is regulated, safe and acceptable healthcare is regulated. When they say home birth is not healthcare, then then home birth is suddenly less safe and less acceptable. It's less safe because it is less acceptable. And he says suddenly in the absence of positive regulation, what might have been a free choice becomes unusual and uncertain. And I think he goes on to say, to apply that in the case of home birth. And they said, what does that look like when home birth is underground? You can't find midwives or supportive obstetricians. When home birth is left outside of the system, then a doctor who backs up midwives for those women can themselves be vulnerable to attack by the other doctors. That's what happens and what it looks like. So again, this all leads to less safety, because what makes home birth safe is integration. There are studies from the countries that have out-of-hospital birth fully integrated, like the Netherlands, show no difference in outcome for the baby, but much more safe for the mother. Countries where it's left underground and marginalized, like the United States, that's where you start to see those differences. And now as a lawyer, I work on those cases. I know exactly what it looks like. It looks like the midwives don't have supportive obstetricians that they can speak to for the tests and the labs that they need. It looks like you call an ambulance to transfer from a birth center or a home birth. The ambulance guys get there. They're not trained or equipped. They know nothing about childbirth. They don't know what a midwife is. I worked on a case where the guys from the ambulance, the midwives are resuscitating the baby. The baby is fine. The baby needs to be transferred with resuscitation to the hospital. The ambulance guys come in, they push the midwife off the baby. Who are you? We're taking over. And then they stand over the baby not knowing neonatal resuscitation, saying, does somebody have the book for, they don't know the rate. Y'all know it's a different respiratory rate. And then the baby dies, and who do they blame? And then they'll turn around and say, see how dangerous home birth is? This is why we leave it underground. That's not how it works. And as this guy says here, when home birth is a hard and a risky choice, sanctions discourage midwives from being able to do it. If it's not integrated, midwives don't feel safe to do it. Without such legal certainty, there is fear and secrecy, which may result in fatal consequences for mother and child. Home birth underground is like abortion underground. It doesn't change women's choices, it makes them die preventable deaths from those choices. So again, what does fear and secrecy look like for midwives? It just looks like anything that makes their actions look marginalized or underground. And coming back to this whole history of the witch hunts and all that stuff we were looking at, think about what's going on there when midwives who are reproductive health care professionals for women, when anything that you could be doing for women could make you less safe. How could that be? How could you be legally vulnerable for supporting women in their reproductive choices? But when you are, that's what leaves women to give birth alone. That's what's happening in the United States. A midwife doesn't feel safe to attend the woman, so the woman knows if I go to the hospital, they're gonna tell me I have to have a C-section, and I know I don't need a C-section. And then I turn to the midwife. Now the midwife feels afraid to attend me because it's outside of the regulations, or there are no regulations, so she doesn't have a midwife. And then she's giving birth alone after 2 prior cesareans, for example, because she's not allowed to have a vaginal birth after 2 prior cesareans at the hospital. That's not safety. So as you look at regulations for midwifery or any of the laws or rules at your hospital or at any clinic that you work, there will be rules that pertain to your work. And you can look at those, even if the policy handbook that you were given, and you ask yourself, do these rules allow me to respect my patient's rights to their body? Is there anything that I'm being taught that where somebody is talking as if I have to do something to a woman, as if I must do something to her, and if I don't, I'm in trouble in some way? Push back and ask, because again, it's not legal, it's not bioethical. Do these laws and rules force midwives to choose between the rule and what they feel to be ethical? The laws and the rules should enforce ethical practice. And when they don't, when they make midwives feel pressure to do something that doesn't feel in integrity with why they came to this profession, then ask yourself, what's wrong with the rule? Does it facilitate integration? You know, essentially, what we're all really talking about here is the possibility for medicine to go from this historical model where the doctor was at the top, the midwife was below the doctor, the nurse is below the midwife, and the woman is somewhere down there at the bottom, to patient-centered care. This is modern medicine. It's the paradigm of modern medicine that can be applied in the context of childbirth, where you have the woman at the center and then the care team working together in collaboration. There does not need to be hierarchy. This is all complementary. The doctor, the midwife, the neonatologist, the doula, everybody working together for the needs of that individual. That's what a healthy system looks like. Examples of good laws. There are some countries that have them. UK does a good job with its laws. You know, keys to advocacy for midwifery is uniting as midwives. And again, I think it would be nice, I'll be done very soon. This is one of my last slides. And I think it would be nice to hear, if any of you want to talk about it, about why you chose midwifery. Why is this your choice? Is it because you think babies are cute? Maybe that's enough. Is it because you love women? Often the difference that I hear between why doulas certainly do what they do. Doulas do what they do because they love women. Midwives usually do what they do because they love women. So, you know, ask yourself, what does it mean to stand also with my other midwives? Because to stand with other midwives also is like standing with women, and it has the same sort of complexities. Prioritize the needs and the voices of the most vulnerable communities. All around the world, studies show that vulnerable groups have higher death rates in childbirth. The more any person giving birth is treated as an other by the people who are taking care of them, the more likely they are to die, to see their baby die, or to come out traumatized. So in the US, it's Black people, any historically discriminated against people. In Europe, it's Roma, for example, or migrants. But that's something to be aware of. Again, it comes back to that centralizing the voice of the patient. When the patient's seen as an other, their voice is less heard. When the patient's voice is not heard, the patient is more likely to die, and the patient is more likely to come out traumatized. The more that patient's voice is at the center of their care, the more likely you are to have a good outcome and a happy customer. Don't settle for scraps, midwives. You deserve to feel respected, honored, paid. Mobilize your clients. If you feel vulnerable within your institution, people love midwives. They love what you do. Get them to advocate for you. Stand on the human rights of birthing women. When midwives advocate on the basis of, I'm standing up for my clients' rights, midwives win. When midwives argue with doctors on the medicine, doctors win, because doctors have the authority over the medicine. Their voices are treated as more authoritative. But reclaim that word safe. Look at that word safe. When we talk about safety in childbirth, what are we talking about? Not only does safety get to include the mother and the mother's future pregnancies and the mother's future babies, but safe also gets to include mental health as well as physical health. A lot of the changes we're seeing in the conversation internationally around childbirth, it goes hand in hand with our recognition that maternal mental health matters. Here in the Czech Republic, as in the United States, 1 in 5 women are coming out of childbirth with some level of trauma. That you have a study here, we had the same study last year, 1 in 5. And here in the Czech Republic, as in the United States, suicide is the leading cause of maternal death. Suicide is the leading cause of maternal death. You all, I have been working for 15 years with women who came out of childbirth suicidal. Often the suicide isn't until many months later, or the wanting to kill themselves. And they're coming out of experiences that their providers probably thought were just another day, where somebody came in and jammed a vacuum extractor up inside them without saying anything, or some circumstance in which they were trying to make the decision, they were asking for information, and they were just being led in circles, gaslit, until they submitted and the thing was done to them. Having your voice overridden at a time of vulnerability causes trauma. So take the extra time, the extra minute or 30 seconds to make sure that you actually listen to that patient. It'll transform everything in the dynamic that you have with them. This is one of the radical midwives I know in the Netherlands. There are 2 midwives in the Netherlands who will drive to support twins and breech births. The Netherlands, their whole system is based on guidelines for transfer from the doctor to the midwife. I mean, from the midwife to the doctor. But until my midwife's case over the twins, nobody had ever looked at the question, well, what if the woman says, no, thank you, I want to stay with a midwife? And these were the two midwives who stood up for that choice. And under Tarnowski versus Hungary, under that decision, the courts of the Netherlands affirm that women get to make the decision about where and with whom they have their baby, including when it's twins, including when it's breech, including all the time. And that midwives have the legal authority to attend them wherever they are. And they said, actually, in the case of my midwife, not only because women have the right to choose, but because physiological twins birth is physiological birth, and midwives are the experts in physiological birth. And they have the expertise to perform those services when they're asked for. So that's my presentation for y'all. And maybe now we can have a little discussion about any thoughts you have on this, whether any of this has been taught to you in your education so far, and how it makes you feel about your choice of career.